I'm Maury Markman, City of Hope Cancer Center, and in today's segment, I'll be talking about four abstracts that were presented at the Gynecologic Oncology session at ASCO. There are obviously a lot more abstracts presented, both oral abstracts, posters, and certainly a lot of discussion that relates to gynecologic cancer. The four in particular I want to mention, in sort of in different realms, not just drug therapy. I should note that the abstracts actually this year's ASCO and the GYN session really actually focused on topics that are really quite relevant that go beyond the question of what is the next best drug, although that's obviously a critical component of what we do in the GYN cancer space and medical oncology and in therapeutics itself, is to look for better options, particularly in the systemic therapy realm. So the first abstract I wanted to briefly mention looked at a quite novel concept. The drug was vobrostolimab, which is a TIGIT inhibitor, which is a checkpoint in our immune system. And this particular drug which is an investigative agent, was co-formulated, the term that was used, with pembrolizumab, which is also obviously a very well-known. So the idea was giving two checkpoint inhibitors together, and this particular abstract looked at patients with mismatch repair deficient endometrial cancer. All of these patients had previously been treated, had not received pembrolizumab before or any other checkpoint inhibitor, but they had been previously treated. There were a total of 40 patients in the trial. 31 had received one prior regimen, and 9 had received 2 or more prior regimens. The bottom line here is the objective response rate seen in this phase 2 study was 65%. And although that by itself is interesting, again, recognizing patients retreated, what was very interesting, the duration of responses in the responding patients, median duration of response was greater than a year. And in fact, 75% of the responders had responses that lasted longer than a year. Obviously, this is an early study. Clearly, much more work needs to be done, but very provocative data in a population where we clearly need additional therapies. 2 immune checkpoint inhibitors, previously treated patients, what role this might play in standard of care in this setting, previously treated, or perhaps in the future, even earlier in the course of the illness.